I'm Haris Antoniades. I'm a professor of cardiovascular medicine. I have a chair of cardiovascular medicine at the University of Oxford, funded by the British Heart Foundation. I'm also the lead PI of the ORFAN study. This is a very ambitious project. It aims to include 250,000 patients who have coronary CT angiograms, cardiac CT scans as part of clinical care, and link these with prospective lifelong outcomes data. The objective of the ORFAN study is to be used as a platform for the development and the validation of AI algorithms that extract information from the CT scans and predict different diseases, either as diagnostics or as prognostic biomarkers. So this, I'll take you through the process of how we came up with this algorithm first. So we know that inflammation in the coronary arteries is what drives atherosclerosis, and what drives heart attacks. It triggers a breakdown of the atherosclerotic plaques. We developed a method a few years ago that uses routine coronary CT angiograms obtained as part of clinical care, and it extracts information from the area around the vessels where the perivascular adipose tissue sits, that are relevant to how inflamed are the arteries adjacent to that fat. So the first biomarker that we developed is called fat attenuation index, and it essentially quantifies these changes in the perivascular space caused by vascular inflammation in the coronary arteries. Now, having developed that biomarker, that imaging biomarker, we included that into a prognostic model by using artificial intelligence modeling, together with other information that we extract from coronary CT angiograms, like information about plaque, information about the risk factors of the patient, and we develop a prognostic model that essentially quantifies the absolute risk of the patient to have a fatal cardiac event over the next 10 years. That was trained in a US primarily population originally, and now in the current study, we are validating that in a large cohort in the UK population, which serves as a true independent external validation of the original algorithm. So this includes the first 40,000 patients from the ORFAN registry. These patients were followed up prospectively for up to a decade. The population were consecutive patients undergoing CT angiography as part of routine clinical care in a number of hospitals from the UK. It was a balanced cohort, a similar number of males and females. All had an indication to have the coronary CT angiography, so most of them had chest pain. But the interesting finding was that only 18% of these people had obstructive coronary artery disease. The rest did not have obstructive coronary artery disease. So the study population is representative of the population that has this test anyway as part of clinical care. Yeah, so the first big finding that we had was that actually those patients who have coronary CT angiography as part of clinical care and they do not have obstructive coronary artery disease, they are also at high risk to have heart attacks over the next decade, the decade after they have the CT scan. Actually, in absolute terms, there are 2 times more patients having heart attacks among those with not obstructive disease at baseline compared to those who were identified as having obstructive disease. This was the first major finding. Then we evaluated the ability of our biomarker, the fat attenuation index score, the FI score, which is what quantifies inflammation in the coronary arteries, against this outcomes data. And we found that in those patients without obstructive disease, in the absence of these significant narrowings, high inflammation in the coronary arteries is related with very high risk for fatal and non-fatal cardiac events that come up to 20 times higher risk compared to their peers of the same age and gender and risk profile. So that was a very, very good validation of the original discovery that inflammation leads to high risk for heart attacks, even in that population that does not have obstructive disease. Then we went on and we tested our actual prognostic algorithm, the AI algorithm, that is called AI risk algorithm. And we have seen that the performance of that algorithm in this independent cohort was extremely good. So there was a nearly perfect alignment between the predicted events and the observed events over a decade, particularly in those people with no obstructive disease. It's very important to note that the population with absolutely no disease, with zero calcium, no plaque, were also at risk to develop heart attacks, fatal and non-fatal, over the next decade. And actually, those people within that group who had high inflammation in the coronary arteries and high predicted risk, they develop events with a hazard ratio of more than 10. So you can identify in this way those hidden risk factors, the inflamed coronary arteries that can lead to heart attacks. In the last part of the study, we tested how this technology can change reclassification, can change the risk category of the patients. And we realized that 30% of the patients who have these tests, they have higher risk than anticipated and 10% lower risk. And when we showed these results to clinicians in an additional study with 744 patients, they recorded that it changed management in 45% of their patients. So not only you identify the people who are at risk, but you guide the clinicians with this kind of technology to decide which patient needs to start statin treatment, increase the dose of statin treatment, or even take colchicine. The conclusion is that among the population that has coronary CT angiograms as part of clinical care, there is a very big number of patients, 80% approximately of this population, who do not have obstructive disease, and they may still be at risk for fatal cardiac events. By using this technology and this algorithm, we can identify those patients and we can treat them effectively. 45% of our patients are currently undertreated, are not appropriately treated, because we ignore this information about inflammation in their coronary arteries. And this is exactly patients that would benefit from this kind of technology. Now, the major limitation, if I can call it that way, is the fact that the registry, was done in patients who had a reason to have coronary artery disease investigation. Most of these patients had chest pain at some point, and they were referred for clinically indicated coronary CT angiography. So the results are not necessarily directly applicable to the general population. However, having said that, you don't go to the general population with a scanner to perform CT angiograms. From the moment you obtain these images and you perform the CT angiogram, then I would advise to go on and get this measurement done. And that's what makes the difference of a very targeted population, which is what we are investigating in this study, compared to the untargeted general population where you deploy any kind of non-imaging diagnostic. So this is the main limitation of the study, that it's not applicable to the general population. AI is everywhere. AI changes everything in medicine, from the interpretation of the findings of the clinical signs of the patient, helping us to search the literature and make decision making, fast screening of patients, improvement of workflows. It's everywhere. It's already happening. The more advanced applications of AI, I see them coming in the field of prognosis, essentially telling us the future, predicting who is going to develop a heart attack, who is going to develop a stroke, who is going to develop cancer, and all these applications are just coming. So it's a matter of time, months, or very few years before we are able to predict most of the diseases in a timely way, allowing us to intervene. And this is the definition of personalized medicine.